start now.
Okay. Yeah, Pamela. So, Pamela, you want this presentation to be off during the start off at the time of introduction?
Yes. Can you just so stop your screen share?
Dr. Ashraf, please stop screen share.
Yeah.
Others, please keep yourself muted and your videos paused.
Okay.
Yeah.
Yes. So, Parimal, giving you the countdown: 5, 4, 3, 2, 1, and we are live.
Good evening, doctors. Good evening, everyone. Welcome all of you for this interactive webinar. Today we have one of the eminent speaker, Dr. Ashraf SM sir, who will be giving highlights on recent advances on SGLT2 inhibitor. Before going into the formal introduction of Dr. Ashraf SM sir from Sun Pharma, we would like to appreciate all healthcare practitioners' efforts during this COVID-19 pandemic. Now we'll introduce Dr. Ashraf sir. Dr. S.M. Ashraf sir is a professor and head of Department of Cardiology in GMC Kannur Pariyaram. Sir has done his MBBS from Calicut, MD from Trivandrum, and DM from Mumbai. Sir has total 16 years of cardiology teaching experience. Sir has published many original articles in different journals. Sir's area of interest is women and heart disease. Sir has conducted nearly 10 state-level conferences and live case transmissions in national and international conferences. So this is Dr. Ashraf SM sir, and sir will be giving a talk on diabetic nephropathy and heart failure, practical issues, and newer treatment. Over to you, sir. You can start your screen share and you can start your presentation.
Hi, very good evening. As today we are discussing very important the practical issues like diabetic nephropathy and heart failure, relatively common two diseases, and mortality and morbidity is very high in these sort of patients. So let me start the importance of heart failure in the cardiovascular complications. So heart failure is the most common cardiovascular complication in type 2 diabetes in the diabetic kidney disease studies indicating cardiorenal interplay. So you see that three important trials, studies, renal, DNT, and altitude. The prevalence of heart failure is almost 14.3 in renal study, and altitude study like 5% heart failure. So depends on the subset. You can see that it starts from 5 to 15%. So relatively very common coexistence between the diabetes and diabetic kidney disease and heart failure. So the type 2 diabetes, cardiovascular, and renal disease are closely interconnected. You see the type 2 and hyperglycemia. There is an acute or chronic disorder, so one of the organ can induce dysfunction in the other. That is called cardiorenal syndrome. The risk of CV death increases as the CKD develops in patients with type 2 diabetes. So elderly patients are more likely to die of heart disease than advancing to end-stage renal disease. So if you take all kidney disease patients, almost 65% the mortality is mainly due to the cardiovascular disease. And that mortality area, the elderly population, the risk is very high when compared to younger patients with diabetic kidney disease. So the patient with heart failure at risk of morbid and fatal events, as many as 1 in 5 patients, people will develop heart failure during their lifetime. You can see this is the data of 4 years back. It affects 64 million people worldwide, and heart failure morbidity and mortality rates are high despite advance in therapy. And in the US alone, the 5-year heart failure the diagnosis is 50%. So the mortality risk is similar to other common cancers of both men and women. If we take the prostate cancer survival in women, the heart failure survival was worse, like breast cancer survival in women. So the heart failure, the mortality and morbidity is very, very grave when compared to the cancer incidence in those population. So what about the Indian prevalence study? You can see that almost 8 to 10 million patients with heart failure in India, and if you take adult population, it's almost 1% heart failure. So the post-admission mortality is almost 20 to 30%. If you take any tertiary hospital, up to 15 to 30% of admissions are cardiac admissions are heart failure related. So the medication adherence ranges from 25 to 50, and India has a relatively younger population, probably higher incidence of diabetes and other comorbid conditions. And incidence of diabetes in heart failure is around 50%. There is a study in Trivandrum registry, it was almost like 55%. So now come the end-stage kidney disease and diabetic kidney disease. You can see that the prevalence and incidence, the diabetes is very high when compared to hypertension or glomerulonephritis. And also rate also, you can see that diabetes is higher. Now come the CKD and yearly risk of death. If there is no nephropathy and diabetes, you can see that 1.4% death rate, and microalbuminuria is almost 3%, but 20% if there is elevated creatinine or renal replacement therapy. So if there is CKD, the death rate is almost increased exponentially. So the kidney disease, among the top causes of the death, you can see that after ischemic heart disease, COPD or cancers and diabetes, CKD comes the 9th rank, and also years of the life lost and years of life with disability, the kidney has more morbid issues in elderly populations. Now, how the diabetes can lead to heart failure? Through two mechanisms, either atherosclerotic or the non-atherosclerotic independent mechanism. Like atherosclerotic mechanism, we all know that it is due to myocardial infarction or recurrent angina or anastomia, whereas without atherosclerosis, that is, the diabetes can induce heart failure due to inflammatory effect on the microvascular endothelium and myocardium with subsequent fibrosis. Some people say diabetic cardiomyopathy, and these can lead to heart failure. So if you take 100 patients, 72% of diabetic patient comes with no heart failure, but in diabetes, the 23% of patients are having diastolic heart failure, and 5% are reduced heart failure. So heart failure is early and forgotten complication type 2 diabetes. So you can see that reduced ejection fraction patient comes with acute pulmonary edema or congestive heart failure. 23% can come with dyspnea exertion. So what are the newer treatment options for heart failure and CKD? We have no other, most of the patients are not receiving ACE inhibitor because if you have eGFR less than 30, for example, creatinine around 1.8, you can't start all these things, but you can start all these if there is early diabetic nephropathy stage 1, 2, 3, and you can give ACE inhibitor ARB, and you have to repeat the creatinine value after 3 weeks. Majority of time it will stabilize or decline, show decline in that, and improvement symptom with ACE inhibitor and survival. And also along with ARB also similar improvement in symptom and survival and hospital admissions, hospitalization for heart failure. Also decreased by ACE inhibitor, ARB and beta blockers. Whereas diuretic will improve the symptom, but it never improve the survival or the hospitalization. And you know the selective adverse events, everybody know that, I am not touching on that. And if you take aldosterone blockers, it will improve the symptom, but also improve the survival and the hospitalization of heart failure. If you take a newer drug like ARNI, that is sacubitril/valsartan combination, it won't improve symptoms, but it will improve the survival and the hospitalization for heart failure. And if you take ivabradine, it also improves the survival in heart failure hospitalization. But personally, I could feel that ARNI will improve the symptoms also majority of our patients. But the studies consistently demonstrated the improvement in the survival and hospitalization with ARNI, but the improvement symptom is not marked with these groups. So heart failure from the prevention to treatment in case of diabetes, you can start the anti-diabetic treatment specific like SGLT2 inhibitors with the preclinical stage of the disease and clinical stage of the disease and advanced heart failure. We have a dapagliflozin in advanced heart failure therapy. So we are going to talk on all these area where the heart failure area, that is this green area, how the SGLT2 inhibitors improve the survival or symptoms or improve the kidney status. So DAPA significantly reduce the risk of CV death or worsening heart failure on top of standard of care by 26%. That is the DAPA HF trial already demonstrated this one. Like that, it also reduced the relative risk reduction in the primary endpoint by almost 18% relative risk reduction. You can see that even after 8 months, it start widening the improvement and the comparison widening after 8 months of therapy with DAPA. So the benefit of DAPA on the CV death or worsening heart failure start even day 28. That is even after 3 to 4 weeks of starting DAPA, there is an improvement. And also it improved and fewer deterioration heart failure symptoms at 8 months. There is correlation with direct correlation with heart failure and the kidney status. If the patient is having congestive heart failure, there is an issue related to the glomerular filtration backward theory and the forward theory. Previously we thought it is because of the hypertension, but nowadays it is due to the congestion and the glomerular pressure exerted by the abdominal venous edema, and all these can make a deterioration of renal function. So when it improves the heart failure symptoms and signs, it indirectly improves the kidney status also. Along with that, you can see that there is a safety result in DAPA HF trial where consistent with the well-established safety profile of DAPA. The adverse event leading to treatment discontinuation. If you take placebo versus DAPA, not much difference, and volume depletion, renal adverse events is almost equal with the placebo. And you can see that fracture, amputation, major hypoglycemia, diabetic ketoacidosis, corneous gangrene is not much difference at all when compared to placebo. So what about patient without diabetes? How it tolerate? The DAPA was well tolerated in group without diabetes. There is a similar study with adverse events and the other volume depletion and renal issues. There is not much difference even with the diabetes and non-diabetic group. So taken as a whole, there is no difference in risk of adverse events between SGLT2 inhibitors and DPP4 inhibitors. And there is no difference at all when compared to serious adverse events or hypoglycemia or major or minor or withdrawal of the tablets. Now come with this, what about DAPA CKD, the proper, how it improved the chronic kidney disease, both heart and kidney. So DAPA in patient with chronic kidney disease, how it started, because to assess whether the treatment is the dapagliflozin compared with the placebo reduce the risk of renal and CV death events in patients with CKD without diabetes who were receiving standard of care including maximum tolerated dose of ACE inhibitors or ARB or like diuretic beta blockers. So there is a 1:1 double-blind trial, DAPA with standard of care with the placebo. Endpoints is one is more than 50% eGFR decline, end-stage kidney disease or renal CV death. Secondary endpoint outcome include composite of sustained decline, CV death or heart failure, hospitalization, and all-cause mortality. So there are primary event decline in, improvement in the renal function, secondaries, cardiovascular and renal parameters. So what they made of that primary composite outcome, the sustained more than 50% eGFR decline and end-stage kidney and renal and CV death, there is a 39% relative risk reduction. Okay, that you can see that after 8 months there is separation of the events and improvement even after 8 months of therapy with the DAPA, and there is a reduction of renal. DAPA 10 milligram with the secondary composite outcome more than eGFR decline in end-stage kidney disease and renal death, and including kidney transplantation, chronic dialysis and renal death, there is 34% relative risk reduction with the DAPA. You can see that after 1 year of the DAPA treatment, there is a slowly reduction in the improvement in the eGFR, and the p-value is very, very significant. And secondary composite outcome, CV death or hospitalization for heart failure, there is 29% relative risk reduction of the DAPA, even with the CV hospitalization heart failure. And all-cause mortality also, there is relative risk reduction of 31% with the DAPA when compared to placebo. And safety outcome and the discontinuation study group, if you compare the DAPA with the placebo, and there is adverse event is almost equal. And if you take any other thing, the safety outcome is almost equivalent to placebo. So that is safety-wise is very, very good. To summary, the DAPA-CKD, the first dedicated renal outcome trial to assess the efficacy and safety of the SGLT2 inhibitor in patients with CKD with or without type 2 diabetes, demonstrated 39% relative risk reduction in the renal subset, and also almost 30% reduction in the hospitalization for heart failure and CV death, and all-cause mortality is almost 31%. So DAPA-CKD built upon the evidence of for dapagliflozin prevention of heart failure and worsening the renal disease in DECLARE and reduction the risk of worsening heart failure and CV death in DAPA-HF. Actually, the DAPA-CKD trials come after the DECLARE subset, and the DAPA-HF showed improvement in the heart failure hospitalization, also improved in the EGFR status. Then only these studies come, and they continued for 2.5 years, showed improvement in the renal status after DAPA therapy. So DAPA-CKD expand the cardiorenal benefit of dapagliflozin in patient CKD. You can see the DECLARE study. This is the cardiovascular arm, this is the renal arm. Both declare the normal individual with a high risk score like atherosclerotic cardiovascular risk score. That subset there is an improvement. DAPA-HF again, heart failure subset there is an improvement, and also improvement in the GFR decline, and also DAPA-CKD, CKD improvement, and you can see the significant p-value. So after ARNI, the major step for the heart failure treatment is SGLT2 inhibitors. So what is the proposed mechanism of cardiorenal benefit? There are a number of pituitary mechanisms